Premature coronary artery disease is in the news, and every day we find one or the other person, film actors, sportsmen, young people, 40 years or 30 years of age, dying of heart disease. Now, the question given to me was that why is it happening at this age? And this question has, engrossed me for the last many years now, because we have been working on risk factors of heart disease for a long time. I begin with a story of a patient. It's not very uncommon. You see all the time, 40 years old, a young person coming with a premature coronary artery disease. This was a physician. 2002, he had acute coronary syndrome, inferior MI. He suddenly collapsed. Fortunately, CPR was done, revived, thrombolized. That time, primary PCI was very far away, at least in the district headquarters. No risk factors, although there was a family history of premature heart disease. There was a two-vessel disease, angioplasty, doing well for the last 20 years. So what's the evidence in epidemiology of premature heart disease is in India? We have been involved in the million death study, trying to understand the causes of death across the country. And in this publication, what we showed was that less than 60 years of age, almost 32% people, 593,000 people died of heart disease. Clearly, it's an epidemic, less than 30 years, less than 60 years, that was the classification. And the global burden of disease has surprisingly taught us lots of new things. These are data from the year 2000 to 2019, and clearly you see that as compared to other parts of the world, China, USA, Europe, Central Europe, and Central Asia, India is the outlier. And in India, what's happening is numbers for premature heart disease less than 55 years of age is increasing. And in year 2019, 286,000 people died of premature heart disease. So the first message is that the disease is not uncommon, it is common. It has been there for a long time. The only issue is that it is increasing in numbers in contrast to data from the developing countries. And the question that has engrossed us for many years now is why is it increasing? What are the risk factors, social factors, genes, other risk factors well known? Are there any unique risk factors? We know diabetes is very common in our part of the world. And there are other risk factors, including quality of clinical care. Risk factors, there have been a number of case control studies, and Interheart was one of them. And the South Asian component of Interheart, which I was also part of the same study, showed that the same risk factors, although occurring at a slightly younger age, were prevalent in Indian population, in South Asian populations, as any other part of the world. Hyperlipidemia, specifically ApoB to ApoA1 ratio, that was measured. Smoking, hypertension, diabetes, same thing. I mean, it's true as in other parts of the world. We had also done a small case control study supported by ICMR, and what we found was this is less than 50 years of age. Smoking, again, came up as a very important risk factor for premature coronary artery disease. And now we have recent data from our own center, about 4,500 patients with undergoing coronary angioplasty, 95% acute coronary syndromes. Smoking, yes, is important. But what is more important also is high non-HDL cholesterol. So the first time, I think somebody has shown that not only smoking, but also lipid levels are important in premature coronary artery disease. This is a cross-sectional. But now we have prospective data from the PURE, Prospective Urban-Rural Epidemiological Study. And what are they trying to show is the fractions of risk. And this study showed 12 risk factors. And what is the importance of risk factors? Clearly, high non-HDL cholesterol was the most important cause of premature coronary artery disease globally. And if number 2 was hypertension, tobacco use, this is myocardial infarction. And if we have data, now we have data also from South Asia, actually. So South Asia, 33,000 people, a median follow-up of 11.5 years. Lots of events have happened in this particular cohort. This is cardiovascular disease, remember, this is not ischemic heart disease, this is oral cardiovascular disease, showing that hypertension was the most important cause. Number 2 is non-HDL cholesterol. Diabetes, of course, is important. But what has come out here is that smoking is slightly low, even as compared to indoor air pollution. And in the current era where pollution is gaining importance as a risk factor, this particular finding is also very important. And what are the risk factor trends? We have been working on this for the last 25, 30 years now, and clearly showing that most of the risk factors, especially obesity and truncal obesity, are rapidly increasing in the urban populations of this country. Hypertension is going up, and not hypercholesterolemia, but non-HDL cholesterol and triglycerides are rapidly increasing. So I think all the lipid risk factors and everything is going up in our country. So triglycerides, you see, are increasing over a period of 25 years. Risk prediction has been used, and we have been using lots of tools to predict risk in patients of coronary artery disease. Unfortunately, if we take this patient, which is the index patient, most of the risk prediction tools, Framingham, the pooled cohort equation, British Q this through, WHO, Interheart, everything, say less than 10%, and at least the established risk factor scoring methods like the European and the American say less than 1% risk of coronary artery disease in this particular patient. So clearly we are missing something. And what is that? That is, I think, genetic risk factors are coming up in a very big way. This morning, Dr. Natarajan from Harvard spoke on genome-wide association studies and use of those in risk prediction, and that's the future. Although the history of genetic risk factors is very old, we all know family history is important. It has been known for the last almost 100 years now, but now we are gradually increasing from one single nucleotide polymorphisms to multiple polymorphisms. And what has been clearly shown in various cohorts, basically Caucasian cohorts, is that as the gene risk score, that is multiple genes, 50, 100, 200, 500. So in the first one, in Europe, Tata used 50 variants, Abraham used 49,000 variants, and now there are 6.6 million variants, and all these show that people in the highest quintile of risk have the highest incidence of coronary artery disease. Clearly, genes also predict the risk of future coronary events. It has been shown both in UK Biobank, and UK Biobank, if you notice the red line, the area under the curve for premature heart disease is much stronger as compared to other groups. So clearly, risk factors are gene risk factors, genome-wide risk association is important as far as the premature coronary artery disease is concerned, also confirmed in Chinese cohort, and also in the India. I think we have done a study known as MedGenome study. This morning you saw the UK Biobank South Asian group and the BRAVE, which is from Bangladesh. And as the gene risk score goes up, the risk of coronary artery disease also goes up. And that's true also for the MedGenome. 2,000 people, cases, 1,000 cases, 1,000 controls. And as the case control definition, if you're in the 95th percentile of gene risk score, it's almost 3.5 times the risk of coronary artery disease. So clearly, they are predicting. So if we use the same gene risk score in our patient, and in this patient we had calculated gene risk score, the prediction value is about 20%. So clearly, beyond normal predictive values, the gene risk score can predict premature coronary artery disease, and I think that's very important for all of us to remember. But can we intervene? And I think that's the second part of my talk. Can we intervene for prevention of premature coronary artery disease, especially when the gene risk is so high? We all know the prevention triangle. Primary prevention is control of risk, ischemic heart disease by control of risk factors. And what's most important thing to realize is that healthy lifestyle attenuates high genetic risk. Now these are 3 cohorts: ERIC cohort in the US, the Women's Genome Health Study also in the US, and the Malmo Diet Study in Sweden and Finland. And all these three have shown that as the gene risk goes up, the risk of heart disease goes up. But if you live a healthy lifestyle, that is the other cohort. So if you live a healthy lifestyle, you can attenuate your gene risk score. And I think that's a very important message, not only for our doctors, because we need to teach our patients to live healthy, but also for public at large, that gene is not destiny. Your destiny lies in your own hands, and you can prevent heart disease. Now, what are these factors? Smoking, we all know. Smoking cessation is critical for control of premature heart disease. Pollution, I call as a new tobacco. And indoor air pollution, I think, is a major factor. Not only in a day-to-day life, we saw that in the PURE study, but also in the film actors and the other people who have died on stage. I think pollution is very important. They all live in polluted atmosphere. Now our younger generation is living in gyms and other areas which are all polluted. So I think indoor pollution is very important, and I think we have to teach our people to move away from the polluting areas so that they have a good, healthy heart style. Physical activity, there is no question. Lots of people have talked about physical activity and what's the physical activity levels that we are recommended. 30 minutes per day, 5 days a week, or preferably 150 minutes, 300 minutes a day, 5 days a week. So I think you can have graded activities, vigorous, intermittent physical activity is also protective. Isometric exercises are protective. About yoga, there are no yoga large trials in primary prevention, but this particular trial, the Yoga Care, in secondary prevention is a marker, although the trial among the intention to treat group was not beneficial, but if you have the people who adhere to yoga, that is the landmark analysis, there is a real benefit. So clearly yoga also is useful for prevention of heart disease. Diet, lots of things have been talked about diet. I won't go into details of that, but there are dietary substances which have preventive effect, the evidences of harm, and then there is equivocal evidence. LDL cholesterol, I think, is the second most important factor that we found in our studies, and it has now been told that getting LDL cholesterol as low as possible for as long as possible is the best way for prevention. And if we want to prevent premature coronary artery disease, I think Dr. Braunwald wrote a very provocative commentary in the European Heart Journal, How to Live 100 Years Before Developing Heart Disease, and he focused on LDL lowering therapies. And we know lowering LDL with statins, at least in these 4 particular trials, in spite of high gene risk, if the cholesterol levels are low, the incidence of events are low. So clearly, there's a message to be gained there. Other things I wasn't going to talk. I just talked about the hypertension management. We need to reduce cardiovascular risk, looking at the whole patient, and we need to move beyond numbers in treatment of hypertension. We need to control their lipids, we need to control their diabetes and inflammation, and I think for that, statins along with hypertensive medication may be a way forward. Aspirin, just a short comment. Aspirin trials have shown benefit for primary prevention, but the harm outweigh the benefit, so clearly, till now, there is no indication. And I think we need to move beyond the tunnel vision of cardiovascular disease, because cardiovascular disease is not only because of risk factors, there are social determinants, and I think we need to understand that there are multiple social determinants of cardiovascular disease. In the recent chapter in the Hearst, we identified 3 of them: location, education, and availability or financing of healthcare. And all these 3 are important. So friends, in conclusion, in the last 35 years, what I've done is to understand the etiopathogenesis of premature coronary artery disease. We have the largest number of premature coronary artery disease patients in the world. Standard risk factors are important, there is no question about it. But gene risk factors, which are also contributing to the standard risk factors are equally important. And I think we need to understand that prevention attenuates genetic risk by focusing on lifestyle or on drugs. And lifestyle, we have standard available therapies. We can modify our risk factors. And then long-term adherence, Professor Chris Granger just talked about them. And finally, I think we need to focus on social determinants. Please do not prescribe a medicine or a therapy which is not affordable. We need to understand the patient in front of us, sitting in front of us, and then we need to prescribe him whatever we have to do. Thank you very much, and thanks again, CSI.